So let us get started. So it is my pleasure to have been asked by Scott Steenberg, who is in charge of multiple things at this meeting, emergency radiology. The refresher courses is part of his responsibilities, and he took over from me 2 years ago. And I have the honor and pleasure of running today's hot topic emergency radiology session. I was just telling my co-speakers when I was in college many decades ago, I had a botany professor, and he told me that you could be a world expert in something if you picked a niche that nobody else was focusing on in about 4 to 5 years. And he was a world expert in something called sphagnum moss. And he would go to the bogs in Scotland every summer when school wasn't in session. And he became a world expert in sphagnum moss in about 5 years. So he practiced what he preached. Now, I don't really pretend to be a world expert in the topic that I'm going to speak on. I just sort of dabble. I'm a generalist and emergency radiologist. I practice at an affiliate of New York University in the New York City area. But my two co-speakers certainly are world experts in their individual topics. And our first speaker, a colleague in emergency radiology, Dr. Bharti Khurana, has really carved a niche for herself and truly is the world expert in this topic. In fact, very recently, she received a major R01 NIH grant. For those of you outside of the US, this is the major funding source. She is going to speak on the topic that she has carved for herself on intimate partner violence. And we're going to hear about this hot topic from her. She has extensive experience over the last multiple years in this area. She's going to give us just a brief overview of this area of great importance, something that I think we haven't really thought about much in emergency radiology and general radiology. But one of the things that I think about is that, you know, the eye does not see what the mind does not know. So if you're not thinking about things like this, it's not going to cross your mind that, maybe I should think about this as a potential etiology. So without further ado, I'm going to call Dr. Khurana to the podium. She is Associate Professor of Radiology at Harvard Medical School, works in the Department of Radiology at the Brigham and Women's Hospital in Boston, and founded actually a center, as you can see, for this. Again, this is unique to my knowledge in the world. And so you're in for, I wouldn't say a treat, because this is really an unfortunate topic that we have to even discuss this, but an extremely important one that we'd like to call to everyone's attention. So I want to thank you all. It's really great attendance to see these many people here for a late session at RSNA. It's wonderful to be back in person. And I want to greet everyone who's on our virtual audience, both live and in the future. Dr. Khurana.
Thank you, Doug, for the generous introduction. So here's my funding information, and these are my non-relevant financial disclosures. So just 3 years ago, in BC, before COVID, the United Nations shared this statement which startled the world. The most dangerous place in the world for women is. So any ideas, any guess? Yeah, everybody knows that. Home, sweet home. Because each year, more than 50% of female homicides are committed by intimate partners. And what's more striking is that women make only 20% of total homicides, but more than 80% of intimate partner homicide victims are women. Now, here's the most disturbing part in this report. These killings were not usually spontaneous incidents, but part of a long-standing escalating abuse. That means you and I, as society and healthcare providers, witnessed these episodes but couldn't do anything about it. So let me take you to my everyday work. I'm an emergency radiologist, and I get one-line history for every study I interpret. So here is a 38-year-old woman strangulated and hit by her husband. So this time she has fractured arm bone, and as I was reading this study, one of her old x-rays popped up on my screen as comparison. This is again fractured arm, but of the other side. And it is from 13 years ago when she was 25. At that time, she reported history of fall, but we know that this fracture is oblique, which is often due to violent pulling, and it has some healing already. Now, in between, she had 68 radiological studies. So, how many times you were imaged between the ages of 25 and 38, which is probably the most productive time for your life, when you're focused on your family and career? How much time can you afford to come to these appointments, not to mention the immense clinical appointments she had at our institution? So we diagnosed her fracture in 2005, but missed her real diagnosis. Her real diagnosis was intimate partner violence, which is defined as a physical, sexual, or emotional violence between current or former partners. Physical assault is still the most common reported IPV. 1 in 4 women and 1 in 9 men have reported experiencing severe form of physical intimate partner violence in their lifetime. Of course, it comes with huge annual healthcare costs. Even children who are exposed to intimate partner violence, the so-called silent victims, have higher ER visits, huge price cost to the society. And most importantly, more than 55% of female homicides have been linked to IPV each year in the United States. Now, the good thing is IPV is preventable, provided it's diagnosed early. Now, our goal is to break the cycle of escalating abuse by making the diagnosis early and preventing severe or life-threatening injuries, because IPV does escalate over time. Now, I want to be very clear. Women or IPV victims want the violence to end, but they don't want to discontinue their relationship. If you intervene early, just like detecting cancer in early stages, radiologists can achieve the goal of ending violence while preserving the relationship. So once again, our goal is not forcing victims or survivors to disclose IPV and leave the relationship, but provide an opportunity for a caring conversation, sharing resources, and prepare a safety plan. Now, the biggest obstacle with IPV detection is underreporting by the victim, the so-called iceberg phenomenon of IPV. Even though there is a high prevalence, we see only the most severe cases of violence and homicides, while the vast majority are submerged, invisible to us. Now, of course, we all understand the barriers for these victims. The victim is often struggling with feelings of fear, embarrassment, and love, and they often justify. Now, if you're thinking that it would not happen to you or someone who is financially independent or well-educated, let me share some stories with you. And we don't have to go too far. So it is close to home. So these statements came when I first started this project. I am good at hiding my bruises because for 16 years, I have walked down the hallway and no one knew. Came from a Brigham radiology technologist. I was in a physically abusive relationship with my physician husband for almost a decade, came from a radiologist. And here's another radiologist. I witnessed my mother getting abused by my physician father frequently. Victims present to healthcare providers before they present to criminal justice or social service. This is the reason we screen for IPV. But the screening is not working. Now, here is the number which gets quoted in ED all the time. 80% of domestic violence or intimate partner violence cases come through ED, but only 5 to 30% are flagged. So we are missing these opportunities. Now, CDC has identified barriers for providers too. Now, the clinicians are often uncomfortable with the topic. They are afraid of offending the patient or partner. There is in general lack of awareness and misconception regarding the risk of exposure to IPV. And of course, there are always time constraints. So there are many, many papers in literature supporting this barrier for clinicians. And I'm just going to share one paper. Here is a survey in the orthopedic literature. So this resident is responding, I have never asked one question. Why? Because he has never seen his attendings asking such questions to the patients. Now, what am I doing as a radiologist? So this poster came out 30 years ago. We all know, we see signs of abuse on radiological studies. The technology has advanced, and now I can make 3D reformations to show these depressed fractures as this victim was beaten with a hammer. But nothing has changed. We just report these injuries, and that's it, move on to the next case. So no wonder the system is broken. I think we report the injuries but often forget the person. Again, I'm speaking for myself, but something we have to think about this. So I think almost 4 years ago, I tried to explore this question. Can a radiologist identify IPV? So we looked at 185 IPV victims. So these are the patients who were reporting intimate partner violence, and compared with age and gender matched 555 controls. And we looked at the radiological reports 5 years prior to their disclosure, and we compared these results. So number of radiological studies were far more in IPV cohort than controls, almost 4 times. OBGYN, abnormal OBGYN findings were more common in IPV, acute fractures more common. Acute fractures of face and skull were more common. Everything was statistically significant here. And old fractures of extremities and nose were more common in domestic violence patients. Now, let's try to understand this better. This is not rocket science. The target area is often the face. Oh, you can see my arrow. So the target area is often the face, and defensive injuries are involving hand, forearm, or shoulder. And they leave visible stigmata on radiological studies, acute injuries, chronic, or healing injuries. So after that study, we proposed the idea of including radiology and AI, and I'll go over why AI, to detect intimate partner violence. I believe that radiologist is the key to this missing puzzle. By recognizing high imaging utilization, location and imaging patterns specific to IPV, old injuries of different body parts, and injuries inconsistent to the history, we can make objective, unbiased report. Now, these patients are not just coming to emergency department, they are showing everywhere because IPV can manifest in many, many ways. Unlike non-accidental trauma in children, we are not recommending additional studies, we are not recommending skeletal survey. Findings are already present on radiological studies, but their significance gets unnoticed. So this is how we have always reported our findings, but now I want you to think differently. So we have target and defensive injuries. So this woman is raising her forearm as she's trying to protect her face. Either her face would get injured or forearm or both, maybe today or maybe a few days later, but we would see that stigmata. So this was our review paper where we tried to define target and defensive injuries. Now, when we first started this work, this picture got media attention. I was actually trying to show that how ulnar fracture is different from radial fracture. So my point was, if you are raising your forearm, trying to protect your face, often it's the medial side of forearm which gets exposed and ulna gets hit. While more commonly fracture radius occurs when you fall on outstretched hands. So I was trying to differentiate the two for the reporter, and it just occurred to me while I was showing that even though we know ulnar fracture doesn't happen with fall and outstretched hand, we never make a big deal of that when we see patients in the ED. We still report ulnar fracture and move on to next study. So I called orthopedic surgeons, and our surgeons were also feeling guilty. They said, no, we never raise concern. We just look at ulnar fracture, we just fix them, move on. And often these are like, they don't even require surgical treatment. So we decided to do a study. So our questions were, does an isolated ulnar fracture in a woman represent IPV? And can we really differentiate an ulnar fracture due to IPV from accidental causes? So I took 3 institutions, only women 18 to 50 years with isolated ulnar fractures. And then based on clinical diagnosis, whether they were disclosing patients of IPV, yes or no, if we are thinking it's because of IPV, and definitely not IPV. So we try to differentiate into 4 groups. Now, 26% of isolated ulnar fractures in women were attributable to IPV. And if we combine suspected patients where we kept on asking, the physician was very concerned, or nurses were concerned, but the patient never accepted IPV, that's like almost 1/3 of women. So 1/3 to 32% of women with isolated ulnar fractures were either confirmed or clinically suspected to have IPV. Now, furthermore, we realized there were differences between the fracture pattern too. So often IPV fracture was just a non-displaced transverse, non-comminuted mid to distal fracture, whereas fractures due to other causes such as MVA were often proximal, comminuted, and much displaced. So there are all these examples of non-displaced ulnar fractures. And it's not just fracture. Remember, I'm not talking only about broken bones, even soft tissue swelling. So make sure you're putting in your reports, because now we are building AI tool, and soft tissue swelling is extremely important. So it's the same analogy. You can have soft tissue swelling along the dorsal or medial forearm. So in the interest of time, I'm just going to go through various fracture patterns we are seeing. So we saw the upper extremity. So of course, we talked about ulnar fractures. But in general, these patients tend to have a lot more hand and finger fractures. And often it's the medial side being defensive, so 4th and 5th finger fractures. And again, often non-comminuted, non-displaced, and these are various examples. And there may be associated injuries of head and neck, head and face, either acute or metachronous injuries. So when I first reported hand and finger fractures, our orthopedic surgeons were not happy. They were like, we see so many finger fractures, we cannot call everything as IPV. So we analyzed this huge national database, because I needed more patients. I needed like more patients reporting IPV, which we didn't have at our institution. So we looked at the national database and analyzed fracture patterns. And our conclusion was that the odds of a finger fracture were 4 times greater in IPV than falling. So if you have a patient with finger fracture and she's reporting fall, that is actually less likely. Then you should consider IPV. So again, this is where you are thinking injuries inconsistent to history. So lower extremity fractures, again, my fellows, I remember when we were analyzing, we were very surprised, because lower extremity fractures were the most common injuries we were seeing in our IPV cohort. And I couldn't really understand why we were seeing foot fractures. So we sat down with our surgeons and social workers to understand what was going on. So often these are still defensive. Often patient is trying to run away as she's probably getting strangulated, she or he. And the other thing is what I learned from social workers, that sometimes they step on their feet too. So again, these injuries were associated with upper extremity, which is again defensive, and craniofacial. So moving on to face. Face we already knew. This is from previous literature, that more than 2/3 of women with facial injuries are assaulted by a husband or boyfriend. And almost 90% of IPV victims sustain facial injuries. And we expected the most common soft tissue, the most common finding would be contusion or soft tissue injury. But our findings were, actually we saw a lot more fractures than soft tissue swelling, and it makes sense. By the time they recommend CT, they are looking for fractures. But soft tissue swelling can be just an incidental finding, but make sure you are putting in your reports. And it's often the mid-face, so nasal bone, mandibular, and orbital fractures, where you will see stigmata of IPV. Again, as in other cases, we didn't see much displacement in more than 90% of patients, and there were associated upper extremity injuries. So these are all examples of face, and then mandible is another area as you are trying to protect. And again, we saw more often on the left side being right hand, assailants being right hand dominant. And this is thoracic injury, actually just came last week. We were seeing a lot more rib fractures, acute rib fractures of right lower anterior. We still have to analyze why we were seeing that area. But this is like just a small cohort. So the other thing you should remember that there is also combination. So if you have a nasal bone fracture and defensive fracture of hand, if you put these two things together, IPV is like very highly likely. Same thing, acute and chronic injuries. So you have an old fracture with new soft tissue swelling, that is also concerning. So while we were doing this, the injury pattern started changing as soon as COVID came. And this is like the first 7 weeks when everybody was scared of COVID. And we compared the patterns from previous 3 years. And we noticed that even though we had fewer patients, we were seeing a lot more high-risk injuries, more severe injuries, and very, very severe injuries. And turns out we never had any grading for these patients. I tried to use injury severity score, which didn't work for IPV. So we developed our own grading, and thanks to that COVID time where all surgeons were available to work on this kind of grading. Here is a quick slide to remind you that IPV is not just bruises and blues. We do see severe injuries, and this is the time it's already known, so we want to avoid that. And we can use historical imaging analysis for IPV prediction. So this is the same ulnar fracture study. I gave all historical imaging to our radiologists and blinded them to the IPV status, and they did a pretty good job. So their specificity was 94% and sensitivity was 75%. So we got encouraged by these results. So for example, this patient had ulnar fracture a few months ago. She had lateral malleolar fracture and then fifth metatarsal base fracture a few months before. So you can start putting things together. And remember, strongest predictor of IPV is frequency rather than severity of injuries. Sometimes our residents get frustrated, like, oh, but there are no injuries. That's not the point. They are coming frequently to ED, so we should take that in account. So you should pay attention to imaging utilization. So here is another study we did, looking at the imaging history as a predictor of IPV. And our results show that our radiologists were able to identify IPV in 47% of patients. So I was very discouraged by this first statement, that we couldn't even diagnose 50% of patients. But among those patients where radiologists could identify, they diagnosed earlier than patients' disclosure by almost a median of 69 months in 53% of patients. So that was encouraging. Now, of course, I'm giving you all this information with the imaging data and clinical data, and we have no time. I start feeling guilty if I'm spending more than 1 minute in reading forearm X-ray. There's no way I can spend so much time. So we know that we have no time to access and review. There are silos of subspecialized radiology. There's always a cognitive overload, and there's always demand to that urgency. So we knew we had to bring AI. So this was our first attempt using only radiology reports. And this tool gave us sensitivity of 64%, which is not good, but it's still better than what's happening right now. Remember, the sensitivity right now of screening study is only 5 to 30%. But the specificity was high, 95%. So now our next phase is to bring clinical predictors to improve the sensitivity. So we have already done radiology. Now we are expanding. So while I'm very proud of this, I want to show this picture. My son actually texted me last year. This was very troubling. How to hit a woman so no one knows was Googled 163 million times during 2020. So while we are learning how to find these injuries, assailants are also learning. So we have to keep up. So this is the reason we started looking at the rare sites too. So, and we expected that. This actually came before that news. So we are learning. This is the time. So do we have a few minutes? Should I? Okay, so this motivated me to dig further. So I started looking at IPV in older patients. So elderly patients more than 60 years where domestic violence was going on for a very long time, if there was any change in injury patterns. So obviously I didn't have enough patients at my institution, so I had to go and analyze national database. And these are the patterns we saw. Actually, so we had fewer head and neck injuries. So we are comparing elderly IPV to regular IPV, so more than 60 versus less than 60. And there were fewer contusions and abrasions, but we were seeing more trunk fractures, so predominantly rib fractures and sprains and strains. But most importantly, there were more hospital admissions. So the idea is, again, we involved our psychologists here, that abusers do become more experienced over time and start avoiding head and neck, that facial area which is more visible, maybe because of grown-up children. So again, we just have to keep learning and different groups. Now, the most important thing in this paper was that more than 1/3 of older IPV victims were men. So I moved on to men because we were just ignoring them. In the past, I kept on using that for women and IPV. I was always thinking IPV happens only to women. But this is the study where we looked we looked only at men. And among men, we tend to see a lot more lacerations. So they don't show that many contusions, but you would see more forearm, arm lacerations. Because it makes sense, because women are always, not always, often use something more powerful. And the worst thing is men do not report IPV. They do see IPV as unmasculine, and they're afraid of being an object of ridicule. Or more importantly, incorrectly accused as primary aggressor. And they don't want to lose custody of their children. So, certain reasons I never even thought about it. And no wonder there are more hospitalizations in men. I can go on, but maybe I'll stop here. Then there are like all these different patterns we are adding to AI. Thank you so much for extra time.
I had a case a few years before Bharti started doing her research. And it was a liver laceration on a CT in a young woman in the ED. And clearly it was liver lac. And there was no history provided of trauma. So I called up the provider in the fast track area, not in the major ED, and I said, I'm looking at a liver lac. What's the history? One of my favorite sayings is, if the imaging and history are discrepant, get a new historian. And they said, there's no history of trauma. I said, you need to talk to this patient in private, because I'm seeing a liver laceration. And they talked to the patient in private, and she admitted that her partner had assaulted her. And this was maybe 3 or 4 years before your research. And I think a lot of this went on, and we just weren't recognizing it. The other point I'll make, and you made that point with your slide and early in the talk with all of those reports, this goes beyond just intimate partner violence, and you alluded to at the end of your talk. There are cases I see where there's scan after scan after scan, and it points to drug abuse, and it points to malingering, and I think we often just say, negative next case. And I'll call the ED and I say, is this person malingering? Are they seeking drugs? So sometimes we have to take a step back and put on a radiologist, a psychologist, or psychiatrist hat. And that's hard in this environment where we're so super busy. But sometimes that extra step makes a huge difference. So we have to think about what we're doing and go a little bit above and beyond just negative next case. Sometimes we have to actually be primary care physicians involved in the team and actually really make a big impact. So some major take-home points, really a tour de force work, Bharti. I'm really congratulations and everything. Let's switch gears in our niche topics here, hot topics, and we're going to talk about another niche topic, which I think is important, which really hasn't received as much attention as it should, and it's a very difficult area to do research in, and that's imaging of abdominal and pelvic trauma in pregnancy, and unfortunately, this does overlap a little bit with intimate partner violence. So we're going to talk briefly about radiology and clinical literature in this topic, talk about the specific circumstances, some pitfalls, the current roles of imaging modalities, and some algorithms. I have no disclosures. I want to thank Dr. Deborah Reed, who isn't here at this meeting. She's chair at Downstate, and years ago and got me involved in a project where we had a publication in radiographics where I mentored one of her residents in some posters that led to a variety of publications. Our most recent publication on this topic just came out a few months ago in MR Clinics of North America. And a lot of help from like the Beatles, help from my friends in terms of getting cases, because this isn't a topic that comes up in terms of not a very common thing that you see. So I have case material from some colleagues. And so this, I was single when I first did this, and then you have a little one, and so it really hits home. It becomes a bit more personal. Here's my little guy. He's now 6.5. Just went to his swimming lesson about an hour ago. Says he wants to be a doctor. I had nothing to do with that whatsoever, of course. Here he was maybe 3 years ago at a Thomas the Tank Engine presentation locally. Timer timer going here. So just, we don't have time to get into the details of radiation safety. There's a lot of controversy about this, but just from a public relations point of view, if we could not irradiate patients at any point in pregnancy, that's ideal. When it comes to trauma, unfortunately, this is one scenario where we may have to. The radiation dose exposure, if we do a single abdominal and pelvic CT, there have been a variety of papers estimating dose in the range of anywhere from, say, 15 to 25 milligray estimate. Depends on the stage of gestation and technique. Things get more problematic later on, of course, in pregnancy, more crowded anatomy, bigger vessels. Cynthia McCullough, world-renowned physicist, has said that the risk is negligible if there's less than 50 milligray, but again, there's a lot of debate. Interestingly, a paper from Ontario province in Canada actually looked at this. It's the first time anybody actually looked at a cohort, very small number compared with a huge number of women pregnant who didn't have exposure, but there was actually no clear increased incidence of malignancy in the children that were born followed over time. But clearly, if we could reduce dose to the point of not compromising quality, that's ideal. We want to document the dose exposure. If there is exposure, ionizing radiation, of course, if we can eliminate it is, again, ideal. And if we have to give iodinated contrast, and we do that in the setting of trauma, appears to be safe. If we're doing MR, and that's really a niche test in the scenarios I'll show, we ideally get informed consent. We can do this at 1.5, and it seems to be safe also at 3 Tesla. A little bit of concern regarding the SAR and pulse sequences, so we should limit the number of sequences we do. And again, seems to be okay at any stage of gestation as far as we can tell for now, over 25 years of doing this when appropriate. Again, that same group in Ontario province showed no known adverse effects, again in a large group of women who didn't have MR compared with those who did. And we don't use IV gadolinium other than in very, very selected circumstances due to concerns in animal models and other considerations. And this is one scenario. If we're going to do an MR, we want to closely monitor the women. We don't just throw them in the scanner and say, okay, call me when the exam is done. We want to be more hands-on. And in general, of course, if we can get away, quote unquote, with ultrasound, and then if we need to MR, that's ideal as opposed to doing CT. We need to consider societal guidelines. The problem is the data with this particular scenario is really limited, and I looked at the data just a week ago, and there really is nothing new to tell you in terms of the more recent literature, and that's because it's exceptionally difficult to do research in this area. You can imagine trying to get an IRB through any kind of institution with this sort of patient population. Very, very difficult. We did a survey now, actually presented at this meeting some years ago, a multi-institutional look in the US and Canada through several societies looking at what folks were doing in practices in terms of their policies in pregnancy. I won't get into the details, but basically in the trauma setting, most practices agreed to do CT in this setting after an inconclusive ultrasound. So in terms of trauma, clearly ultrasound is what we would do initially, even though it's quite limited. Trauma is due to falls, it's due to motor vehicle collisions, and unfortunately it's due, in many instances, to non-accidental trauma, intimate partner violence. And these women can be difficult to assess because of the normal changes in physiology. It can range from seemingly minimal falls that can be potentially life-threatening to the fetus, and the data is very variable in terms of fetal morbidity and mortality. And the data shows that women tend to be over-admitted but under-treated, and there's a range of potential very bad outcomes, especially in the 3rd trimester, from both blunt and penetrating trauma. We need accurate and rapid imaging. The problem is it's very difficult to know how to do this with not a lot of good data to guide us. Clearly in this scenario, the mother comes first. And if the mother is of limited mentation, that makes it very, very problematic. We're not going to talk about radiography. It has a really minimal role at this point in time. So we'll focus first on sonography. Certainly has its role as an initial test. We can check for fetal heart rate. We can check the placenta, and we check for free fluid. There are a variety of papers on this. Most of the work on this comes from the UC San Diego group, Michelle Brown and others. have shown that this is a reasonably acceptable test for looking for free fluid. You should actually not have free fluid in pregnancy in the pelvis. If you do, it's a red flag. But in terms of looking for organ injury, it is pretty limited, and especially later on in gestation, and you can imagine why in terms of the ability to see things. Very difficult, especially later on. And this is true, we know this in the FAST exam setting in people who are not pregnant, even more difficult, especially later on in gestation. Their data showed also the yield is, fairly limited, and especially if you're going to image everybody who has any sort of trauma, the yield's going to be low in the pregnancy setting. So again, help from my friends. This is from my colleagues in Europe. This is a case of a woman who fell down a flight, some stairs, and here's a perirenal hematoma nicely demonstrated on sonography, and here's the fetus in early gestation. Here's a case from my institution, MO Doppler. Fetus looks normal, 16 weeks, and we didn't see any injuries to the fetus and didn't see any other injuries elsewhere. This was a small series from the group at UC Davis showing major limitations of ultrasound, and this is well documented in the GYN ultrasound literature, OB literature, in terms of the inability to accurately assess for abruptions later on in gestation. CT is actually a better test. It's not a great test. It has its limitations, especially later on, because there are a lot of things in the, quote, aging placenta that can give you false positives. So as the placenta, quote, ages, you have things like infarcts, cotyledons, and other things that may make it look like there are potentially areas of decreased perfusion or infarctions and stuff that are related to trauma, but they're not. But the sensitivity is actually very high, at least in this small series that was retrospective. But ultrasound really did very poorly in this series, and that is consistent with the prior OB literature. So again, the take-home point here is that you really should not have free fluid in the asymptomatic pregnant patient. If we see a little bit of free fluid in the non-pregnant patient, that's very common. In this setting, you should not see it. If you see it, that is a red flag. But here's the problem. Again, third trimester, we have a lot of limitations inherently. If the SONA was negative, it really comes down to a clinical call. What was the mechanism? What's the index of suspicion clinically? What should you do? Does everybody get a CT of the abdomen, pelvis, torso? Do you do an MR? What do you image? An interesting paper from the UC Davis group, Mike Corwin. They showed in a retrospective series when they didn't look at the pelvis, they sort of subtracted it, but they had already done it. They showed that they only missed a few things, but should we be doing that in actual practice if there was enough of a mechanism? Don't know. Should we reduce the dose? This is one scenario where I really think we should definitely not use very low radiation dose technique, but again, how low do you go? Nobody knows, to my knowledge, the answer to this. So these are questions that remain uncertain. Again, I looked at the literature as recently as like 2 weeks ago. What is well known, and this is some older papers from University of Texas and elsewhere, that clearly if you really want to see substantial injuries, CT clearly is the way to go for looking at the abdomen and pelvis, as with our non-pregnant population. We've known this for decades, and you can see, interestingly and unfortunately, injuries to the placenta, injuries to the fetus itself, to the skull, to extremities, to body parts within the fetus. They're certainly not common, thankfully, because the fetus is relatively protected, but when there's major mechanisms of injury, you can see these. And I'd be very careful. I have even seen legal cases sent to me where there were misses in terms of injuries to the placenta. And again, there are false negatives and positives, and the appearance is variable. And so there are references, again, not a huge amount of literature, but there are references that have shown that these things can be missed and they can potentially be correctly identified prospectively. So areas of devascularization, areas of abruption, and even active hemorrhage, as I'll show. So we have to be careful. Again, we want to make an accurate diagnosis, but we don't want to have multiple overlapping acquisitions. We don't want to have multiple passes, but we want to have image quality be acceptable so that we can make an accurate diagnosis. This, again, is not the time to be using ultra-low radiation dose technique. I'm not sure the exact reason for this. No offense to anybody who's from the state of Arizona. My apologies ahead of time. But for some reason in the Phoenix area in Maricopa County, there seems to be a lot of pregnancy-related trauma, motor vehicle collisions. This is, to date, the largest such series of its kind in the world. And they had a very high yield as well. And so they looked in retrospect at these individuals, these women who had, particularly in later gestation, at the placenta. And not surprisingly, when there was large areas of devascularization on CT in the placenta, the greater the volume estimated on retrospective review, the poorer the outcome, the greater the need prospectively, and these women were treated for emergency delivery, and again, the worse the outcome. Again, I've never seen anything even closely, remotely near these numbers, so I'm not quite sure why they have this huge series, and nobody's even come close to reporting this number of placental injuries on CT, but that is, to my knowledge, the biggest such series of its kind in the world's literature. Other considerations, particularly later in gestation, the third trimester, the bladder gets elevated, the kidneys are larger, organs just get bigger in later stages of gestation, they're more susceptible to injury. The uterus pushes the liver and spleen up and lateral against the ribs, they're more susceptible to injury. It's more likely to have retroperitoneal bleeding because we see, the ovarian adnexal vessels are just big. They actually cause problems. It's more difficult to reliably identify the appendix on cross-sectional imaging when it really gets late in gestation. And these are more likely to bleed in the setting of trauma. And so therefore, again, later in gestation, it's more likely to have hemorrhage, more likely to have pelvic fractures and associated fetal injury. So here's what we would see, relatively later on in gestation, some heterogeneity of the placenta, but no evidence for injury. The placenta is intact. There's no separation, no active bleeding, no bleeding into the amniotic cavity, no evidence of fetal injury. In contrast, this is two cases from Cookie Menius, now our editor of radiographics, and her colleague Vinnie Melnick at MIR. Cookie's moved on to the Mayo system. Here are two patients, this patient in the setting of pregnancy and trauma with a central liver laceration, a different patient with a splenic injury. They're pregnant. They were treated conservatively in the setting of motor vehicular trauma, and they did okay. In contrast, this was a case from some years ago at my institution. Again, we don't see this that often, thankfully. 36 years old, 24 weeks pregnant, in an MVC, and you can see she's got a major liver laceration. There's some perihepatic hemorrhage. There's a big cleft in the placenta. There's active arterial bleeding. There's a lot of hemorrhage coming out of the placenta. And this woman survived, but unfortunately the fetus did not. And we correctly called all of this prospectively. And they knew this fetus was in danger. The doptones were pretty much absent, but they were able to save the mom. And sometimes when everything is abnormal, if you're not familiar with what things should look like, you might not appreciate it if you've not seen what a placenta is supposed to look like. This whole thing is devascularized. There's basically no flow at all here. And this, again, a case from Mallinckrodt from some years ago from Cookie and Vinnie. And there's bleeding extending into the lower amniotic cavity in the vagina, and this fetus did not survive. And I thank them for their contributions. Here's a case from Jorge Soto at Boston University Medical Center. And again, this was unfortunately intimate partner violence. This was the significant other who was stabbed. And this is why they did a triple contrast exam, rectal contrast. I think there was oral and also IV, and here is the acute traumatic lumbar region hernia with hematoma, but no bowel injury, and patient is pregnant. So MR, there's almost nothing in the literature on this, just more sort of position papers about how this could potentially be used. And even CT, there's still to date nothing really from any society, no even medium-sized paper looking at the utilization of this with or without ultrasound. MR clearly is more challenging in terms of patient monitoring and access, but we've done it a few times. Others have as well. Costa Raptis, who's Vinnie's colleague and co-chief of emergency radiology at Mallinckrodt, Washington, St. Louis, 8 years ago or so, had a position paper in radiographics. This came out of a paper called, a poster called Trauma Mama, which is sort of cutesy, suggesting the following uses for MR for problem solving after initial CT and substantial trauma. If the patient becomes symptomatic, if you need to do a follow-up imaging, you don't want to further irradiate the patient, to further look at soft tissue injuries, because we know MR is superior for that, and if there's possibility of spinal injuries, and also for looking at the placenta better. Here's one of the few cases we've done over the years in the trauma setting. Certainly we do a fair amount, I would say maybe a few of these a week for non-traumatic indications, appendicitis, gallbladder and biliary tract, urolithiasis, etc. That's very well established now. I've been doing that for probably 15 years at this point. Trauma, not so much. Patient who's 24 weeks pregnant, she refused CT because of the concern of ionizing radiation. She was stable. It was a low index of suspicion. We have a little bit of hydro pregnancy, and everything looked fine. So in this kind of a setting, she's stable, low risk. We had no issues doing that. And certainly, everybody's different. At my institution, we, for years, have been able to do 24/7 MRI in that kind of a setting. Here's a case again from my colleagues, Dr. Mario Scaglione in southern Italy. And this is someone who has some soft tissue injuries, 30-year-old first trimester of pregnancy. She's got an effusion here in the pleural space. She's got some soft tissue injury and some ascites. So very nicely demonstrated on MR. In terms of ultrasound, again, we can certainly look at the fetus, heart rate, placenta, look at gestational age, and again, there are some things we need to do, and our sonographers to make sure that the mother is comfortable and the baby is not compromised. So in conclusion, we've gone over a brief review of the, to my knowledge, current roles of these imaging modalities in the setting of trauma. In the occasional situation where a woman ends up being pregnant, and we didn't know that, and we do a routine imaging exam, we always want to, image gently and wisely. So here I'm going to show you a 30-year-old from, again, my colleagues in Europe who was in a motor vehicle collision, and they didn't know about it, that she was pregnant, and sometimes there's just no time to do a pregnancy test. And there's, fractures, and there's hematoma, prevesical injury, and oops, it's subtle, but there's a round configuration to the endometrial cavity, and she ends up being early pregnant. There's been some efforts from the GYN community to integrate this sort of algorithm into the ALTLS protocol. That's still underway. Clinicians still don't know the kind of things that I'm talking about, so that we need to educate them. And I really like this quote from some years ago, actually from the urologists, which is inaccurate myths or delayed diagnoses may represent a more significant risk to the patient, which is really two patients, right, fetus and mother, than the radiation risk. Some more recent references. Here's our article in our clinics and some of the recent references I came across. So here's my little guy, graduating 2 years ago, and I thank you very much for your attention. So we're going to run a little bit late, but again, I appreciate everybody's participation, attendance. Our final presentation, again, from another world expert in a niche topic. This is Dr. Armonde Baghdanian, and he has carved a niche for himself in this unique topic, which is damage control surgery. Somebody is involved in a major trauma and they go directly to surgery and then they get imaged and we see a mess, and how do we decipher that?
All right, good afternoon, everybody. My name is Armonde Baghdanian from the University of Southern California, Keck Medical Center. I have nothing to disclose. And so we're going to talk about damage control surgery today. Essentially, what is damage control surgery, specifically in abdominal pelvic trauma patients, the surgical technique involved and the clinical perspectives, and also the role of CT imaging. We're also going to show a bunch of imaging appearances of the DCS abdomen with case examples and pitfalls. So what patients undergo damage control surgery? These are patients that show up to your trauma bay. They've had severe abdominal pelvic traumatic injury. They are hemodynamically unstable, and they immediately need to go to the OR for life-saving laparotomy. And what makes these patients unique in comparison to other trauma patients is that they have metabolic derangements that put them at risk for a progressive hemorrhagic coagulopathy. So clinical research has shown that these patients present with endogenous coagulopathy, acidosis, and hypothermia. And this hemorrhagic coagulopathy, if it's not detected early and putting these patients on a course for the damage control process, really increases the mortality and morbidity of these patients. So let's talk about what that is exactly. In surgical circles, the hemorrhagic coagulopathy is known as the bloody vicious cycle. Patients undergo this life-threatening trauma. There's hemorrhage, and various physiologic and iatrogenic factors lead to this triad of core hypothermia, metabolic acidosis, and coagulopathy, which leads again to this progressive systemic coagulopathy. So this leads to essentially non-surgical bleeding in these patients if it is left unchecked. What that means is these patients will literally ooze hemorrhage from mucosal surfaces, from cut surfaces, and from injuries to solid organs. This is not controllable either surgically or medically if this state is reached. So prolonged operating room time leads to exacerbation of this coagulation cascade, and it increases patient mortality. So it's important to identify these patients early and know who they are and to put them on this course. And so what is that exactly? In 1982, Dr. Stone, a surgeon, introduced the paradigm shift with an unprecedented 65% survival rate among liver trauma patients in comparison to the historical 7%. And he used the stage laparotomy technique, which is multiple laparotomies performed over time. And this is when damage control surgery was born. So looking at these three boxes down below, in the initial laparotomy, when that patient hits the trauma bay, the major concern is to arrest active hemorrhage. After that point, the secondary concern is to limit bowel and bladder contamination within the peritoneum, and surgeons try to spend about 60 to 90 minutes in the OR, but they want to take this patient to the ICU to resuscitate them to reverse those metabolic derangements I spoke about. They plan to come back to the operating room in 24 to 48 hours for surgical treatment of the injuries that were initially seen, or complete surgical treatment. So how does CT imaging, where do we come in to play within this specific process? And as you could tell from the scout images, these are very daunting cases when you initially see them. So after the initial laparotomy, CT may be performed to look for injuries in unexplored areas, to look at the stability of surgical repairs, and to look for foreign bodies, fractures, and intracranial injuries. As these patients have not had any imaging performed, they've gone straight to the OR. If a life-threatening injury is noted, then the patient immediately returns to the operating room. Now, when they're in the ICU getting resuscitation, they may have CT imaging done due to the lack of response to transfusions, worsening metabolic derangements, or persistent hypotension and the need for pressors. In that case, they may get imaged, and again, life-threatening injury is present, they return to the operating room. As far as optimizing the CT protocol, it's not very different from various level 1 trauma protocols. Non-contrast imaging is obtained to help differentiate between hyperattenuating foreign bodies, small bone fragments, bullet fragments, previously administered contrast within the operating room from active extravasation of contrast and bowel leaks. IV contrast is performed typically with multi-phase imaging, arterial portal venous phase, with consideration of delayed phase imaging in order to find that small blush of contrast that represents active bleeding. In addition, it'll help you detect post-traumatic vascular malformations like pseudoaneurysms or AV fistulas. Now, the point to make is oral and rectal contrast, which may not be typically administered and is essential in these patients, and I'll explain on a later slide why that is. But if there's concern for bowel injury in damage control surgery patients, you want to use oral and rectal contrast, particularly in penetrating trauma, and we'll go more into detail on a later slide. Dual energy CT may be used to use virtual non-contrast imaging, reduce radiation dose, and again, help differentiate various hyperattenuating materials and potentially different types of contrast material, whether it's enteric contrast versus IV contrast. In the case of patients that have compound pelvic fractures, there's always going to be concern for active bleeding within the pelvis, and also concern for bladder injury. In that case, the multi-phase imaging may be extended into the pelvis. In addition, a CT cystogram may be performed to look for bladder injury. And in the case of high-grade renal injury, a pyelographic phase may be performed to look for collecting system injury and also ureteral injury. So now, coming back to anterior contrast, or so to speak, doing maybe a triple contrast scan in these patients, why is that essential? And it's essential because these patients have just had surgery. They literally have an open abdomen. So the secondary findings of bowel injury lack specificity. Findings of bowel wall thickening, edema, mesenteric stranding, free air, mesenteric air, all those things are already present. Therefore, using anterior contrast is essential if there's suspicion, and again, particularly in patients with penetrating trauma. So here we can see two coronal images in this patient. There's a barely discernible stomach injury. It's actually not discernible. I don't think anybody would call that unless they could see into the future. But oral contrast was administered through an enteric tube. There's adjacent surgical drains in the right image, and you can see that there's a leak from an enterotomy involving the stomach. This is another patient that had a rapid deceleration injury from a motor vehicle collision. And you can notice on the coronal image on the right that there's marked edema of the duodenum. Oral contrast was administered, and this patient had a leak pointed out by the arrows and required a patch repair of that enterotomy over there. And here's another patient. I remember first looking at this case and was surprised. The first thing I thought is like contrast ascites. And in the left descending colon, in the first image, you can see a large laceration. There's adjacent small bullet fragments next to the white arrow. There's contrast seen on the middle and the right images extending all the way up to the liver. So this was a rectal contrast enhanced exam. On the middle delayed phase image, you can see a collecting system injury, a grade 4 renal injury, and also there's a pancreatic tail injury in the middle image pointed out by the arrowhead where there's an adjacent hematoma. On the right image, you can see the bullet fragment within the splenic fossa. So these patients, on this cartoon image, you can see a bunch of imaging findings that you can see in these patients, and literally every single one of these patients may have all of these findings, and we'll go through case examples of these. So these patients can present with shock, foreign bodies, retained surgical instruments, altered anatomy, incomplete surgeries where ends of bowel are just ligated, they're not anastomosed, ostomies are not performed, and also traumatic fractures, literally resected organs, and all of them will have open abdomens. So as these patients get aggressive IV hydration in the shock state, it causes extensive visceral edema. There's extensive skin thickening. You can see on the 3D rendering of the axial image on the right. And so closure of these abdomens, if you wanted to do it, is difficult and has increased rates of wound dehiscence. In addition to that, the surgeon's already planning to go back in to complete the operation. That's why they have an open abdomen in the first place. Also, closing the abdomen early is associated with an increased risk of compartment syndrome. On the image on the right, I don't know why we can't see our arrow, but this one works. No. But on the image on the right, you can see that there's suture markers adjacent to a bowel loop in the right anterolateral abdomen, and that's actually an end-ligated loop of bowel that was never anastomosed, as they plan to come back and do a primary anastomosis later. Another feature of these patients is abdominal packing. These abdomens are open, and packing is placed in areas where there's concern for persistent injury. It is also placed in severely traumatized patients throughout the 4 quadrants of the abdomen and the pelvis. And the surgeons will go back and take out the packing and look to see if there's persistent bleeding, bowel staining, bowel on the packing, fecal matter on the packing material to assess for persistent or unknown injuries. So here on the top image, you can see packing material anterior and posterior to the left lobe of the liver. You can see a bullet fragment within the liver with a liver laceration anteriorly, and that had hemostasis, was not bleeding. And on the bottom image, you can see packing material anterior and posterior to the liver. In this next image, you can see how all these patients, again, have an open abdomen. There's packing material within the pelvis, demarcated by the red arrows. The packing material absorbs air and adjacent fluid, whatever it is, and can mimic, leaked stool, perforated bowel, anything like that. The arrows on this delayed phase axial CT show the preserved ureters, and you can see bullet fragments anterior to the sacrum related to the gunshot injury, with a bullet fragment in the dorsal subcutaneous tissues. And this is kind of a pretty striking image of a patient. Here's the scout, the coronal and axial image of this patient. The red arrows denote packing material, and the yellow arrows actually denote the native bowel of this patient, the large bowel that has some enteric contrast within it. You can see how closely the packing material actually resembles the large bowel. It's almost hard to differentiate. It can also mimic abscess, hematoma, stool, or a loop of colon, as I just mentioned. And the radio-opaque band, if you're not familiar with it, can mimic a bullet or bone fragment. So if you're unsure, it's good to look at the scout image and correlate with the CT images to see exactly where the packing material is placed. Also, in these patients, they frequently present with multi-organ trauma. They, on average, can have 2 visci injured. And so in the scout image, you could see that there's a towel clip open abdomen, there's surgical packing material denoted by the white arrows, there are external fixation devices of the bilateral femur fractures. This patient was shot and fell from a height to the ground. And on the axial images, you see an arterial phase image and a portal venous phase image. The left kidney is enlarged, demonstrates arterial injury with the white curved arrows, and the venous image, the portal venous phase image all the way on the right shows a venous injury as well. So there's multivessel intraparenchymal bleeding in this enlarged kidney. Also, packing material can be seen throughout the abdomen, and the way they close the abdomen is causing beam hardening that's limiting evaluation of the anterior abdomen. Now, the same patient on the delayed phase image on top, there's an axial delayed phase image through the pelvis. You can see a distal right ureteral injury where there's a leak. So the distal right ureter was avulsed. And on the bottom 3 images, you see a CT cystogram. There's a bullet fragment within the right iliac bone in the middle image. And on the right image, you can see a laceration of the posterior bladder with a leak of contrast. So this one patient had all these injuries. Dr. Steenberg's group wrote one of the few papers on this topic. He did a retrospective look at these patients that had surgery and had CT within 24 to 48 hours. They looked at a 90-patient cohort, and similar to the surgical literature, a majority of these patients, the etiology of trauma was penetrating, whether gunshot or stab wounds, and they looked at areas that were surgically explored, areas that were surgically unexplored, and also sites that were of suspicion surgically or clinically for persistent injury. And in the 90-patient cohort, 19 had unidentified injuries on the CT after damage control surgery that was performed within 24 to 48 hours. 8 of these had clinically significant injuries, and by clinically significant, I mean they required further surgery immediately, angiographic intervention, or orthopedic intervention. So looking at these cases, you have to know what was surgically explored versus unexplored, and it's important to communicate with the surgical team and know the various surgical maneuvers to understand this. So in surgically unexplored areas, they may be unknown injuries, and in surgically explored areas, they may be persistent injuries or failed surgical repairs. So knowing what the surgeons do will help us better understand where to look for possible unknown injuries. So in these cartoon renditions, from one of the original papers we wrote, you can see that incision of the right-sided peritoneal reflection of the duodenum, the right hemicolon, and incising that diagonal line, which is the root of the mesentery, it extends from the cecum to the ligament of Treitz, and lifting up the small bowel, you have access to see the entire right-sided retroperitoneum. And if that's not done, then an injury can be missed in that location. The Maddox maneuver is when they get access to the left-sided retroperitoneal structures. And so you incise the left-sided stomach, the left hemicolon peritoneal reflection. You lift up the left-sided structures and you get access to the left retroperitoneum. The surgeons will not go into the retroperitoneum in that first laparotomy if they don't suspect an injury because it takes time. So unless there's active bleeding, the etiology of trauma is suspicious, or there's an expanding hematoma, they try not to go into it because they want to get to the ICU to resuscitate the patient. So it's important to look at these areas as there can be missed injuries, but also know that the peritoneal boundaries are now violated, and so contrast may not go in the expected locations that you think. So now going through some sample cases in surgically unexplored areas, this patient has an open abdomen. The right retroperitoneum was never explored. You can see a hematoma displacing the right kidney anteriorly, and there's an area of active extravasation within the hematoma that is seen. In this other patient, there's a liver laceration that was known, that was controlled surgically. There's a small splenic injury. You can see packing material anterior to the spleen where there's a small adjacent bullet fragment. The right side of the lesser sac was never explored. A laceration is clearly seen through the pancreatic head. And this led to an ERCP that showed a main pancreatic duct leak that ended up getting stented. Now, looking at surgically explored areas, you look for persistent injuries. Remember, these patients are coagulopathic. It's very hard to control solid organ injuries. So even though they are treated surgically, it does not mean that they are safe. So in this patient, we can see arterial, portal venous, and delayed phase axial images through the liver. This patient had electrocautery of a right-sided liver laceration. A small focus on the left image, a small blush is seen that expands on the more delayed images. And this person had a failed, essentially, surgical treatment and persistent hemorrhage within a liver laceration. And the other area to look at is sites of surgical suspicion. So these are sites that the surgeons are suspicious for injury, whether they were explored or unexplored, whether it's due to the etiology of the trauma or what was seen in the initial laparotomy. So it's important to, again, communicate with the surgical team, what did you guys do, but also what are you suspicious for? So here's a patient that was found to have compound pelvic fractures, because remember, these patients are never imaged before they go to laparotomy. Packing material was placed within the pelvis as there was some small oozing of blood. And on the arterial phase image on the left, posterior to the pubic symphysis, you can see that there's hemorrhage that expands on the delayed phase imaging on the right. And so where you see packing material, you want to pay closer attention, as there can be persistent sites. There can be areas that are of concern for persistent or unknown injuries. Here's another patient. This is from, thanks to Dr. Scott Steenberg. And this patient, you can see, has extensive packing throughout the abdomen on the scout image. They had hemostasis at surgery of a complex liver laceration. Packing material was placed on top of the liver lacerations, and you can see that there is foci of active extravasation that is denoted by the arrows. So whenever there's liver trauma in these coagulopathic patients, you want to look very closely at them, like your chest colleagues look for lung nodules, because you want to find that small focus of active extravasation that can be detrimental to this patient. And here's another patient that has an open abdomen, has edematous bowel loops kind of eviscerating themselves through the abdominal defect. They removed some of the packing material and saw that it was stained with bile. This person also had an emergent cholecystectomy and a hepatectomy with packing material placed within the surgical defect. You can see in the top right image. And the HIDA scan shows that there's a clear bile leak where it was suspected. So in conclusion, in these severely traumatized patients, you have to know that they're prone to life-threatening metabolic derangements, including coagulopathy, and they may meet criteria to undergo damage control surgery. And it's crucial that we as radiologists are familiar with these common post-damage control surgery findings. We communicate with the surgical team so to optimize our own protocol, be aware of what was explored and unexplored, and to be attentive to sites that are suspicious for injury. So these are my references, and special thanks to Dr. Steenberg, Dr. Katz for this invitation. We wrote a book chapter on this analysis of emergency imaging from head to toe you can refer to for additional details. Also to Dr. Jorge Soto, who brought this topic up to me for the first time. I think we wrote the first radiology paper on this, a review paper in ER radiology in 2016, which seems like yesterday. So thank you very much, and that's it.
So in the interest of time, we're running over. I'll ask our other two speakers to stick around for a little bit. And no, I had nothing to do with him showing my book, so just full disclosure. Thank you very much for attending. Really great session. Appreciate everybody attending so late. Thank you very, very much. And again, to our virtual audience as well.